Hi, I'm Marianne Ayre. I'm a doctor of psychology and I'm here to talk to you about eating disorders and mental health today. I guess the first thing I'd start with is what exactly is an eating disorder? And there's probably about 6 categories that are contributing to eating disorders, but in mental health we generally go with anorexia nervosa, bulimia nervosa and what we call OSFED, so an eating disorder otherwise specified. So anorexia nervosa is usually somebody who's underweight, are very concerned about putting on weight. In fact, they're actually terrified of putting on weight. Generally, there are no compensatory behaviours, but they can compensate with exercise. Having said that, generally they just restrict food. Most don't eat food at all. They just try and avoid food, full stop. They have this intense fear of gaining weight, so telling them to eat is not going to work. And they also have an intense fear that they'll put on weight if they even look at something like one grape. Therefore, it's very difficult to work with people with anorexia nervosa. Bulimia nervosa is characterised by repeated episodes of binge eating and compensatory behaviours. So a binge for somebody with bulimia nervosa usually entails an enormously large amount of food. It can be planned or unplanned. It's often emotionally driven, and when they start to binge, they often cannot stop until they get a sensation that they can't fit any more in. This then is followed up by purging generally, or other compensatory behaviours, which will be excessive exercise, or even taking things like prescribed or unprescribed medication. It might be Ipecac or other things like that for the compensatory behaviours. Binge eating disorder is characterised by eating large amounts of food, but it continues on through the day and it doesn't stop. This is characterised by overweight and other medical complications as well. And other specified eating disorders is somewhere in between somebody who has anorexia nervosa and somebody who has bulimia nervosa. So they might not meet all the symptoms, but it's just as serious and just as bad for them. Of course, there are a number of other little ones that we won't talk about today because they usually belong more in the medical model than they do in the psychology model. So the next category we'll move into will be the common comorbidities of an eating disorder. Now, this is really important, I guess, because we're not just dealing with an eating disorder as such. We're not just dealing with somebody who doesn't want to eat or somebody who overeats and purges. We're dealing with a lot of comorbidity. Major depression is in 68% of people who have bulimia nervosa. In anorexia nervosa, it's in about 40% of people. OCD is also a common comorbidity, and that's over 25% of people in both disorders. Social phobia and agoraphobia is quite high. Alcohol can be very high. There's a bit of drug dependency, more so in bulimia nervosa, and that's about reducing weight, reducing hunger. And there is quite a bit of PTSD, which we need to be concerned about. So when you say that somebody has an eating disorder, you need to think about all those comorbidities as well. We're not just treating one, we're treating the lot. And so this is why we really need to triage treatment. We need a psychologist, we need a dietitian, and we need the GP involved to triage that sort of treatment so we can keep an eye on it. Also, you might ask about medication and its effectiveness. Generally, and I've got this from quite a number of eating disorder centres around the world, they have said that they will generally just give an antidepressant or an SSRI regardless. One of the problems with that is that people with compensatory behaviours don't actually keep much of it down, as you can imagine. So if you try and treat some of the comorbidities with medication, they may not take them because they're fearing that the medication will put on weight or do something quite unusual for them. So they don't trust medication. But you can try in that sense. But it's best, I guess, to just keep an eye on the suicidal rates, etc., when they're doing this. So you might want to know what sort of assessments are required for somebody with a severe eating disorder. For the GP, when we work in a triage system, we want the GP to look after all the medical assessments. We want bloods, bone density, ECG, BMI, However, ongoing impact on the body, particularly for somebody who is purging, will probably include further investigations. The issue around this is that people who are purging, which could be people with anorexia or bulimia, or OSFED, of course, they can be upsetting their electrolytes quite a bit. So that has a heavy impact on the heart. Because they're purging, I suppose, and the acid from the stomach, they have often esophagus problems and teeth decay. So keeping an eye on all this is very important for them. Bloods, of course, are to just manage the electrolytes. However, it's a bit of a furphy in the sense that, as you know, if they drop weight, their electrolytes will be a bit unstable at the time, but then they'll just catch up. So it's a bit like, it won't really tell you. What we are probably looking for is when to catch that little drop beforehand, when it happens, I suppose, before it stabilises itself again, but still really, really important. A lot of our clients, I've had a number of people with who've had bone density tests and have, as young as 20, and you probably know this already, have early osteoporosis. And you know, it's interesting because when you talk to the clients about this, they just, because they're so young, I guess, they say, well, it doesn't matter, it hasn't happened yet. And we talk about the impact that can have on the body, on childbearing, etc. But it's hard for them, the eating issue is more important to them than any medical condition. So it's a bit hard then to try and talk to them about those sort of things. However, it's just information, education around that is important. For the therapist or the clinician, the psychologist will look at numerous standardised questionnaires for depression, anxiety, quality of life and PTSD, and also self-harm. However, interviews around these are best. So really a risk assessment is probably the best protocol for that. It's best to monitor face-to-face interview as opposed to copious questionnaires, I think. What we often try and do is arrange with the GP and the dietitian, if we can have those involved, who is going to do the weighing. Because our clients are usually absolutely terrified of getting on scales. Even though they might weigh themselves at home 6 times a day, for somebody else to know about their weight is quite frightening for them. So it's good to organise who will do that rather than have everybody do it, because it's just too overwhelming for them. It's best to do it at the beginning of the session, so then you can talk to them about it and settle them down about that anxiety around the weighing issue. Also with the three triage, the GP, the dietitian and the psychologist usually, that communication is really, really important, because a lot of the clients tend to keep secrets from one to the other. So they might tell the dietitian one thing and they'll tell the psychologist a totally other thing, and then they'll tell the GP something else entirely. So that open communication is really, really important, so that we're all treating the same factors. So there's a lot of psychoeducation around what's going on for them and why it's going on. The dietitian will look after the quality of food and the nourishment that's in the food, but we need to really just get them to eat a little bit of something and then move them slowly into a regular pattern. But telling them to just eat can be very difficult, and if they're involved with their family, it's very frustrating for the family. We need to sometimes actually even have a chat to the family about how to manage these things, or the partner about how to manage these things, because they get quite frustrated and they can't understand why they can't just eat. But at some point, by the time they seek help from a professional, it's just gone on so long that they're stuck in that mindset and they can't move from that. The problem with the clients is that the goalposts keep moving. So if I ask somebody who's struggling with their weight issues, I say, well, how much is going to be enough? They don't have a goal for that generally. Some people with anorexia nervosa might have something very, very light, like 45. But when they reach 45, which is dangerous, of course, for most of them, it's still not enough. So a lot of work has to go around those cognitions and what's going on there. It's difficult to treat because A, we've got the comorbidities. B, I guess they come to see you about their eating disorder when it's gone too far for them, generally. So they're more stuck in the eating disorder. Often when I've asked them why are they seeking treatment now, they'll just say, well, I can't function anymore. But they might not be able to function at their job anymore. They might not be able to think clearly anymore. And it's also at that point where they're already established certain rituals around eating and food and exercise. And it's also attacked their sense of worth, self-worth, and what they think about themselves and how they think about themselves. When we talk about the BMI chart, and you're probably familiar with the BMI chart, anybody around 14 and under, that's quite a dangerous level, and refeeding is important, and possibly hospitalisation for a short period of time. And then on discharge, they really need a team to be discharged into to help with that as well. Over that, I guess when we look at over 14, BMI of 14, we're looking at BMI around 15. When you're on this low or lower BMI, what's going to happen is that 80% of the thinking of the client relates to food or safety behaviours around food, not self, around food. So how can I avoid food? How can I purge and then get rid of that food? What am I going to purge on? What am I going to binge on? Sometimes these compensatory behaviours are quite huge, especially for bulimia, because they tend to purge a lot more than people with anorexia nervosa, so their electrolytes can be totally out of balance. That can be a planned binge or a non-planned binge, depending on where they are. So if they're planning a binge, they will plan what food goes into that binge, which is usually something quite high in calories and fat. So it could be a loaf of bread with peanut butter and a tub of ice cream or something like that. It could be 12 packets of biscuits. So in a sense, it's very, very expensive. And the family, if they're still living at home, are often quite frustrated with being eaten out of house and home. I've also had some clients who are living in shared houses who eat other people's food, and they end up getting kicked out of that accommodation. So a lot of the behaviours are actually interfering with their quality of life, but they can't stop it. Around their brain, the surface around their brain has started to shrink, and therefore it impacts greatly on their ability to think in any way, problem solving or fixing the situation. And that's what makes it, again, really, really difficult to treat. So when we get to a BMI of 15 to 17, for instance, 60% of their thinking relates to food and safety behaviours. Even a BMI, we like a BMI of 23 or 25, but a BMI of 19, we find, after years and years of being a clinician, is generally the lowest we can get to for them to be reasonably safe of all those other medical complications that set in because of the eating disorder. But even then, the ability to problem solve, to fix things, etc., is still limited in the brain. So when you think of complications, we've got to think of all those things. The comorbidity, what happens to the brain and how it impacts on the ability to problem solve. And what happens is it just takes over. The only topic is food and weight and how to keep it at that level that they prefer. So when we talk about treatment for people with eating disorders, monitoring is really important, but we're also trying to treat comorbidity. We're trying to treat the brain and how much function it has, because it doesn't problem solve at all. A lot of it involves psychoeducation. For the psychologist, the first few sessions are really about building rapport and doing some education around the eating disorder and the impact on their bodies medically and otherwise. And then we might move into some therapy related stuff around the eating disorder. But having a good rapport with our clients is very, very important. Even in the GP, it's very important as well. People often ask about hopping on the scales. It is very scary. The clinician generally talks to them about why we need to hop on the scales, and it's usually a non-negotiable. So generally for treatment, we don't want to collude with the client who is quite distressed around what they want to do. We are the professionals, and so there are some non-negotiables, and weighing is a non-negotiable. Once the triage has decided who's going to do that, that will happen at the beginning of the session and shared with the other clinicians involved, the GP, the dietitian, the psychologist. The second non-negotiable is really generally that treatment from all people. The assessments, etc., are non-negotiable as well. And generally the biggest non-negotiable will be to get them to contract with you not to lose any more weight. As I said to you before, treating the comorbidities doesn't often work with medication because they're purging so much, they don't keep much down. However, we need to be aware of the comorbidities and how they impact on the eating disorder, particularly around rituals. A lot of our clients have an incredible amount of rituals. Let's take exercise, for instance. They must do 100 push-ups or sit-ups or something or other, and if they don't, something bad will happen. They'll put on 10 kilos. And this is their thinking. Other rituals. I had a client at one stage who would drive all around Newcastle to the local stores to find a particular brand of food because she would not eat any other food except that brand of food. And that was for her, it was like the world will cave in if she couldn't find that particular brand of food. Other things might include an enormous amount of laxatives. I've had clients who have taken an enormous amount of laxatives and are so fearful that they'll run out of laxatives. They've had them hidden all around the house. We have to try and wean them off that. And around that is a lot of psychoeducation around the eating disorder and how those behaviours are impacting on the eating disorder itself. As a clinician, we often are aware of the behaviours and we talk about the behaviours and how they keep the eating disorder going. It's very hard for them to break rituals, particularly if OCD is involved. And we need to really establish, if possible, the difference between an OCD ritual and an eating disorder ritual, which can be quite complicated because they can take on a very similar appearance. Of course, we know if excessive hand washing is usually about germs, and locking and unlocking doors is often about fear of safety. But if it's really moving food around the plate and only eating coloured food at the beginning, I'll eat this colour, that colour, that colour, that's more about a food-related disorder. Now, these particular issues I'm talking to you about as a psychologist, however, I might not be aware of these. You might be as a GP, or the dietitian might be more aware of these things, and that's why the shared information is very, very important. Our clients have a lot of ritual around exercise, and while we don't necessarily want them to completely stop, we do want them to reduce the time spent exercising. So our clients might go for a 10-kilometre run, but then they'll do a lot of other exercise as well, sometimes adding up to about 3 hours a day. This is very unhealthy, particularly for somebody who's got an eating disorder. It's okay for somebody in professional sport, but if they've got an eating disorder, it's unhealthy for them, because they're not actually providing the fuel that's required for that sort of exercise, as you're aware. Therefore, it takes its toll on other parts of the body. So what we try and get them to agree to, and that's not going to happen very quickly, but we try and get them to agree to basically no more than an hour a day of exercise. Even that's probably a little bit excessive, but we can't take everything off them immediately. There's two things that we're not able to do. One is to get them to eat, and one of them is to stop exercising. We have to gradually introduce those concepts, get them to eat, and basically we don't care if they just eat a grape a day. If they're not eating anything, that's better than nothing. But one of the first things I often have to start with is water, drinking water, because often the clients are quite dehydrated with all that purging, and getting them to drink water is quite difficult. Now, some of the things, having said that, some of the things we have to monitor before we weigh. A few questions might be called for, like when did you last have a drink? When did you last eat, if at all, etc., because they can do some water loading. Our clients who are really into all these rituals are often on websites that help them to maintain the path of restrictions or purging. Therefore, they all know about water loading. They know how to make themselves heavy in their pockets. We generally get them to take their shoes off, and if they've got jumpers, etc. on, we get them to take those off as well. We want their true weight as opposed to a weight with shoes and coats and etc. on. And it's important for the therapy to be effective. Body perception is are really important for our clients. And this is all about the self-esteem. A lot of our clients would not go to the beach with swimwear. A lot of our clients would not even change in a dressing room. A lot of our clients, particularly anorexia clients, wear oversized clothing. So we have a number of physical things that we can actually visually see when we have the client in the room, such as dehydration. We can usually see that. With anorexia, there's often some fine downy hair on the face that might grow. The baggy clothes and the jumpers in summer could indicate they're getting very cold, so thermostat, so to speak, is out of whack. There are things like that that give us indications that something physical on the medical side is going on there that might need to be addressed. I guess self-esteem is really big, and I guess the struggle with weight is huge. As I said to you before, we never know, they don't know where the goalposts are. Once they reach a certain weight, it's not enough, so they have to lose more weight. And that's really, really difficult. So as a psychologist, we'd have to negotiate what is a safe weight for them. We roughly estimate that around the BMI and look at a safe weight at what we could tolerate. So as I said, we could tolerate a BMI of 90 as a sort of a clinician, but we can't tolerate a BMI of 80. Why? Because that starts putting them in the dangerous zone, and they're obviously not eating enough to maintain it. But we would prefer a BMI of 23. BMI is a guesstimate, as you know. It's a chart that's been statistically added out, but we have to use this as some sort of safety net to estimate what's going on for our clients, and also to look at if there's a big drop, and a sudden drop in weight is very serious. I just thought I'd use some of the case studies I've seen over the years to talk to you about some of the extreme behaviours some of our clients might go through. I had a client once who tattooed just above her knee so that she could actually measure that component of her leg every day to make sure that it hasn't gained any weight. We also have clients who don't look at themselves in the mirror. We do have clients who weigh themselves 6 to 10 times a day, which means nothing. We've also had clients who have their own natural laxatives. Some of the others would going out and pretending to eat with their friends. Oh yes, I went out to dinner the other night with my friends, but actually when you get down to it and ask them what they actually ate, they may have just had some soda and some lettuce or something, but would they finish their plate? Would they empty their plate? No, they wouldn't do that at all. Or they would say, I've already eaten. A number of clients will say, if they're living with the family, they say, I cook the meals. And they tell the family that they've sampled while they were cooking, which means that they don't have to sit down with the family and eat. Our clients are generally very honest with us and tell us what they do because they want to get better. They don't necessarily want to eat, but they want to get better. So they're usually pretty upfront with all that. Some clients will never eat with their family. It's just too confronting for them, and the family might be a little bit too observant, I guess. So they'll eat afterwards, but they really won't eat at all. So there's a lot of secrets, and there's a lot of ways they use to get around the secrets as well. And if they're accused of something with the family, they'll deny it generally because it's quite embarrassing. They are actually very embarrassed about the eating behaviours. It's not something that they're proud of, and I think that's very important for you to keep in mind. And when it gets to this serious nature, they don't do it deliberately. They are compelled to do it. And so it's really important to go very gently with these things. Fortunately, mental health offer 40 sessions a year, which is probably still not enough, but it's much better. It has improved under Medicare. And this is important because regular, especially at the beginning of the treatment, regular sessions with the client is very, very important.
Welcome to the GP Psychiatry Support Line information sessions for general practitioners. I'm very honoured today to have Dr Marianne Ayre, who has provided a talk on eating disorders. Marianne has a background in academic research, and she's worked in the areas of eating disorders, complex personality disorders, and she's worked for a long time within the public system, but also works in the private system with some very complex patients. I've worked alongside Marianne over the past year or so, and it's been a really wonderful experience to see the depth of her understanding in relation to the psychological challenges that people you might see in everyday practice may present with. So Marianne, welcome.
Thank you.
And thank you for providing a presentation to our colleagues. Today I'm really interested in just finding out a little bit about how you approach developing rapport with somebody who has been referred to you for review of an eating disorder. What kind of tips do you have for our colleagues?
I think probably the major one would be to listen, really. They've come with an issue. Sometimes they're actually brought by parents or family with an issue, so they're not really wanting to be there, so there's some reluctance going on. And so really it's about asking them about what they're experiencing and how they relate to the world regarding, in relation to their eating disorder. A lot of people start getting help because they stop functioning in life. Like they can't even do their work anymore or study anymore because the eating disorder is getting in the way. So often they've probably had it for a couple of years before you even see them. So it's going to be very hard and complex. So building rapport is really just, I guess, really about giving empathy and saying this is really tough, but let's see what we can do. Let's see if we can work together. I'm not making you do anything, but we'll see how we can, get on top of this and make it work. Most of the response is, I don't want to put on weight. When we do have some non-negotiables. So basically one of the non-negotiables is, that's okay, but we can't have you losing any more.
Okay.
Otherwise, you're colluding with them and that's not really going to work at all. So, and we ask them how they're going to do that, how are we going to work that out?
Okay.
Yeah.
So I guess you're intimating that there'll be some resistance, and resistance is to be expected.
Sure.
So how would you advise our colleagues to manage that resistance when it comes up? Because oftentimes, certainly in general practice, people present and they want help.
Yes.
And they're likely to be compliant.
Yes.
So just talk a little bit about how you manage resistance within that context.
Within eating disorders, they're sort of compliant. They might want help, but they don't want the help that you want to give them. So as long as I don't put on weight, I'll be compliant. And that's where you start. You've got to have a starting point. And that's probably the starting point. Okay, we're not going to put on weight, but we don't want to lose weight. So how are we going to work this out? A lot of education around it, a lot of psychoeducation, and I guess for GPs too, that would be important. So, because a lot of the GPs really, the concern is, of course, blood tests, the electrolytes and where they're at, depending on whether they're losing weight. But even people who are bulimic and purge a lot can have problems with their electrolytes, as you're aware. So we do want some blood tests, and they're usually compliant with medical tests a lot. So we'll get some blood tests, but as you probably know, they're a bit like a chameleon. I mean, we're just trying to get the point where they don't come back and meet one another. So the blood tests may drop at some point, but then of course they level up again. And we're trying to just catch that where they drop point to see what's going on there. So blood tests, we do want bone density tests, we do want ECG tests. So for the GP, looking at that sort of symptomology, plus asking them if they ever have any pain in the stomach or how their bowels are going, that sort of medical stuff is really, really important. Yeah. And so once they just interview about general stuff, then perhaps slide into eating and what's going on there. And are they prepared to talk about it? And are they prepared to get weighed? Which is really, really difficult because a lot of them don't want to get weighed at all. You can usually cajole them. And some of them say, well, I'll get weighed, but I don't want to know the number. And that's okay. Some say, I'll get weighed, but I don't want you to know the number. And that's pointless. So we just need to slowly just ease into it. And you might not get everything you want in the first session with them for the GPs.
Sure.
You get the test done and maybe they can come back. So it's sort of like building rapport that way.
Yeah.
It does involve probably at the beginning weekly to see the GP just to touch base and get that rapport going.
Thanks. So oftentimes the eating disorder exists in a context. Well, always it'll exist in a context. And so, for our colleagues who might be seeing an adolescent as opposed to an adult, do you have a sort of differential approach? So when you're forecasting therapy, I mean, is your therapy with an adolescent always going to be one-on-one, or how would you approach an adolescent differently from an adult? Not only in terms of the way you set up the frame of reference of therapy, but also just in terms of working with the family system. So what would you do?
There's a number of different models out there. The Maudsley model is totally family systems. And you can work in various ways. And while that's a good model, I find some of the adolescents are very rebellious with family and resistant. My preference is to see, always have the teenager as the client, and have a couple of sessions with the family as well, but also just check in with the client on the teenager regularly as well, on a regular basis, on a one-on-one basis.
Right.
I find the issue is when the family are all there, there's those dynamics that can be very, very difficult. And I just remember seeing, it was the child and the teenage child and the mother. And all the mother could go on about was the money she was having to spend on the plumber because of the purging, the degree of purging and the plumbing stuffing up. It wasn't focused on the child having an eating disorder and the serious nature of that. So that was quite difficult. So it was best for me to see the mother separately, just to a little bit of education around what's happening without the child hearing about other problems. Because I think the teenager picks up the impression that they don't matter when they hear that sort of, if there's that sort of conflict within the family.
Yeah.
So I think seeing the teenager on a couple of times on their own to have some rapport, and then seeing the parents with the teenager to see how everything's moving forward is good. Often the parents don't understand. They often say, look, if they just eat, so there's a lot of anger around the fact that they're not just eating. But of course, it's mental health. It's more than just eating, as you know.
Yes. And so that's the context of working with adolescents. I mean, if you're working with adults, your approach is different in terms of understanding relational dynamics. But do you feel it's sort of less important to have a partner or a family member engaged, or do you bring that sort of process later on in the therapy? We
engage first with the client, the adult. Sometimes the family or the partner will ask to see you, but we have to get, of course, adult consenting, they have to consent to that.
Yeah.
What I've found is that the majority of them don't want them involved. They want to work it out on their own. Perhaps it could be for many reasons. The family have had too much control and they don't want them taking more control. Various things are going on there. If the eating disorder, for instance, anorexia, severe anorexia, who are perhaps, dropping below the BMI of 14, for instance, quite thin and at high risk. If they need to go into hospital, well, that's definitely, we need to bring the family in and talk about the serious nature and what has to happen at that point.
Yeah.
As I said, the family, it's more about education.
Okay. Yeah. Now, from time to time, our colleagues will experience a crisis.
Sure.
And that's when somebody comes in and they might be depressed and suicidal in the context of an eating disorder. Now, that's kind of challenging because perhaps the person doesn't need to be in a general hospital because their BMI isn't critically low.
Yes.
Yeah. But at the same time, they're at risk because perhaps they're very anxious, they're experiencing a sense of hopelessness. My experience is that medications sometimes can be helpful, but the evidence base is pretty poor in that regard. What's your experience in terms of whether you've seen any relevant, reasonable clinical change when people have been started on SSRIs?
If they are suicidal and depressed, it's not so much the suicidation because that's a phase, but if there's been some chronic depression, sometimes an SSRI can work. It doesn't work solely for eating disorders because generally, particularly if one of their compensation behaviours is purging, they're not going to retain a great deal of it at all.
Yeah.
And they're, especially those who are refusing to eat virtually anything, they're not going to take a tablet because it might put on weight.
Yes.
They're absolutely terrified of any medication that will put on weight. And we have some people who have serious other mental health issues, because as you know, there's a lot of comorbidity, and they're put on, they might be put on an olanzapine or something else that does put on weight. So they just refuse to take it, which means they're very complicated in that sense.
Yes. Okay, so Marianne, I'd love to hear about your experience, your clinical experience. Just hear a little bit about a case vignette. Does anything come to mind?
Yes, I will talk about one woman. Now, she was about 34 when I first saw her for an eating disorder. She was referred for an eating disorder. After about 2 sessions, I realised that there was a lot more going on in this case. So we were just talking about what she would eat. She was very anorexic, but not at high risk. She was suicidal, but not at high risk. And when I had a look at what she was eating, the types of food and how much, one of the things she actually said to me was she was eating hot chilies. And I thought, that's an unusual vegetable to pick. And I said, why hot chilies? And she said, because it burns all the way down and it burns all the way up. So there was a lot more to that case. She was self-harming in many ways, more than that. And in fact, when she was diagnosed with borderline personality disorder, and anorexia nervosa and her restrictive eating was more of an emotional eating, or not eating. She didn't dare eat. One of her traumas involved eating disgusting stuff. And so eating was more about a trauma as well. And this became a very complex case, as you can imagine. She was even compensating quite severely with laxatives.
Right.
So, and I only found this out because we do ask about laxatives, of course, and compensatory behaviours, but one of the reasons I found this out was that she actually got charged for stealing laxatives. Right. In actual fact, she had about 1,000 laxatives hidden around her house, like in pot plants, all around her house, I later discovered. And so she didn't need to steal any because she had a lot, but she was so paranoid she would run out of these laxatives. So she was taking about 40 a day. The recommended dosage was 4. So again, that was another almost an addiction-like thing that we had to wean her off. Stopping cold turkey was going to cause her a lot of problems as well. So we had to wean her back from that, which took weeks and weeks and weeks. So we were working on a lot more than just an eating disorder. And it took time. We did get to wean her off the laxatives, and we did manage to prevent other self-harm. We still then were struggling with eating and regular eating because the trauma was still there. So we had to start working on that next. So there's a lot of work that we have to put behind the eating disorders. And as you can imagine, it takes a long time.
Yeah, how long were you working with this?
I was working with her for a couple of years.
Okay.
Yeah.
And so taking a longitudinal perspective and really, I mean, in terms of your experience, in terms of the speed of change, what are your thoughts in terms of expectation for, when you're setting a frame for the person and the family, what kind of frame do you set in terms of duration of treatment? Look,
it's hard to estimate. It is based on a number of things. The case I spoke to you about, this person had this problem since she was like 12. So there's a lot of years of doing this behaviour that becomes ritual or ritualised. And but if they're in their teens, it depends on how long they've had it. Why? I always ask the clients, or try and tease out, why an eating disorder? Why not something else? And there's reasons behind that. And if we can get to the bottom of that and work with that as well, alongside that eating disorder, we usually can get a lot more success. The other thing is that there's a lot of cognitions built in, and it's usually on self-worth. I will be better when I am this weight. And the problem with this weight is that when they get to that weight, it becomes this weight or this weight, and it just keeps rolling. So they're never really happy. So we have to work on getting them to start seeing some sort of value in life and being healthy, accepting their body. some of that is more entrenched with some than others, so it can take a while. We were only given initially, I think, 12 weeks.
Mm-hmm.
We didn't get very far at all in helping people with eating disorders.
You spoke a bit about that dissatisfaction with their own body habitus and the way they look. And there's some interesting articles more recently about the impact of social media and filters on the various social media platform. I'm just out of interest, I mean, have you seen any more unique technology associated presentations over the past couple of years?
I've had quite unusual ones, I must say, and it had to do with avatars and game playing. Now, I'm not tech savvy, I don't know much about this stuff. I learn from the people I see, really. But this person had this avatar and had an online relationship with another avatar that became so intense that I was confused as the clinician to know if that was if they also had a relationship outside of the game, or was this all in the game? And it was all in the game. And therefore the eating disorder was triggered by having to reach the measurements of this avatar.
Wow.
Which of course was quite unrealistic, really.
So they're quite extraordinary pressures on young people today, aren't they?
Yes, yeah.
So do you have thoughts about, there are reports that we're seeing more young males experiencing eating disorders, and I had the opportunity to meet with a research group from the UK a few years ago, and they were hypothesising that there were organic disorders more common in young men, and that was explaining why we're seeing an increased incidence of boys and male adolescents presenting with eating disorders. But I don't think that's been borne out. I think that was an initial hypothesis when I say a few years ago. I think it was 2002.
Look, it's interesting you say that, because there was actually a study that came out of the AFL in Victoria probably about 15 years ago, and I think the lifestyle's changed now, but the culture in Australia and possibly other countries is after the game you celebrate with meat pie and beer. And they couldn't do that and keep their standard weight, and they were weighed to play this game.
Right.
It was, I don't know whether it's a coach thing that just thought they had to stay underweight or whatever, because I mean they do a lot of exercise. So they had to maintain this weight for the next game, be part of the culture. And so there were a number of men who became quite unwell and anorexic as a result. They were doing lots of compensatory behaviours. And when you think about it, for a guy in particular playing AFL, they are very physically active, not only in the game but in the training for the game. So they're doing lots of physical activity, and yet here they are restricting themselves again on top of that to keep to this weight. It's that was happening back then, and it wouldn't surprise me if more of that's happening now. And I think we have been seeing a few more males. I think it's hard for males to admit they have an issue with this type of thing. So, but I think once we make it a little bit more, we become aware of it and maybe talk to them about it, they can then say, yes, we're having a problem with this. Especially because there's a program out now which I've never been on, and I'm not familiar with it, but TikTok, I've told, for a number of teens, and they are presenting these very unusual bodies, these slender bodies, along with dance, and that's the sort of the model to aim for, basically.
Fascinating. So
scary.
Social expectation is almost creating an internal map of what we should look like, which is creating anxiety within our young people to conform to that model. So we've got, avatars, and we've got that entire world where people are creating an ideal that they're trying to aim for, and through that process they end up developing an eating disorder. Do you think the family context and behaviours within the family context of mum and dad and siblings, is that a risk factor?
Risk factor, it's a good question, because the family do influence in that way, and I'll give you a couple of examples from cases I've seen. One person became quite a gym junkie and ate less to have a connection with her dad. And that's the only way she could see that she could connect with her dad, is if she went to the gym with him and upheld his ideas around diet and exercise, like the gym, which was quite sad. Others, it comes from the family. It can actually come often from the parents, about the ideals about you're going to get fat if you eat that cake, or you're going to do this. Just these little comments that might feel like they're just playing around, but if that's happening at school with that same person, they will take it to heart. And those sort of things can trigger quite quickly.
I'm really interested to hear a little bit about your experience of hearing the voice of the patients and their experience of their family.
I have a number of examples of that patients have told me that might be interesting and useful. But also some of the engaging behaviours the patient takes up to disguise their lack of eating with the family. You'd be surprised probably to know that a lot of our patients take up the cooking if they're in a family. So they'll cook for the family, and one of the things they'll often say is, well, I ate while I was cooking, so I don't have to sit down with the family. Another thing is they'll often become vegan or vegetarian, so they can reduce those sorts of things. The family can get quite frustrated with all these little rituals that they develop around food, because they'll say, well, cook for yourself because I'm not cooking that. All these sorts of things. Also, the family try and put a lot on their plate and encourage them to eat because they know there's an issue, but they don't know how to handle it, which is not going to work because they'll spend so long sitting there moving food around their plate, and the family give up and leave the table, and then of course they can just hoik it or give it to the dog that's under the table. These sorts of things occur. They get more and more frustrated, I think, the family, particularly with binge eaters as well, because a binge, most of it is emotionally driven. So, but in saying that, for a binge eater, they have time to plan. So they may be, say, at work or at uni and something bad's happened, and they know they'll go home and they'll binge. So they either have a stack of food at home themselves under the bed, or they'll just go into the pantry and eat a lot of food from the pantry. And I've had clients who have been in shared houses and they will binge on all the food in the shared house, and they can't replace it because they haven't got any money, and then they've been kicked out of that shared home because it's been ongoing and they couldn't stop. A binge is quite difficult for a lot of people to understand while we're on that, because they really can't stop. It's out of control. They don't know when to stop. I say, well, if you had your binge food and I said, now stop, they just said, I just couldn't do it. I couldn't stop there. I'd have to keep going until I get some sort of sensation in the body that tells them to stop, which then often proceeds with purging. The family find that really, really difficult.
Of course, I mean, in relation to binge eating, oftentimes I'll be referred to review people with a binge eating disorder, and oftentimes there's complex comorbidity, trauma, anxiety disorders as well. My general approach is, if I've got a really solid team, there's a psychologist, a dietitian in place, GP working effectively, sometimes I'll actually trial medication for binge eating disorders, and there's a reasonable evidence base around something like lisdexamfetamine or topiramate, which is quite a toxic substance, but I get a reasonable treatment response, but I think that's probably something that needs to be managed by a specialist and in a team context. But I have seen reasonable remission in people who are often working within a trauma-informed frame as well, often with, it might be our movement desensitization and reprocessing, managing trauma and anxiety, and I'll use pharmacology whilst they're focusing on those trauma issues to stabilise it, binge eating. And I get a reasonable success rate with that. But binge eating is often misunderstood. It's not easily diagnosed. There's a lot of shame associated with it.
So it often comes to you later. So it's been running for a bit longer because nobody really notices it. It's a bit of a secret, really.
Yeah.
I guess too, with binge eating, it's often more emotionally driven. So it's an emotional dysregulation disorder. Can be a trauma behind it, of course. But I think with EMDR, or eye movement desensitization, we can actually work on focusing on the urge to binge as or a trauma, if that's there as well, and if it's emerged from that, which helps quite a lot. So we actually focus more on the upsetting thing that led them to the urge that led them to the binge. So that if we can manage that, and they can manage that better, then the binge doesn't occur. We can't focus on just stop binging because that's just not going to happen. And we've had people who have been quite extreme, where they get into rituals like, I'm only going to eat this brand of whatever. And they've had to drive to like maybe 10 places to find that brand because they weren't going to eat any other brand. So binges are quite complex in the sense that they can hold off until they get exactly the food that they're going to binge on. Some have binge-only food. And I guess when we're talking about binging, it's about eating an enormous amount of food in one sitting. It's not like Christmas where you overeat, or Easter where you eat too much chocolate. It's like, it's an enormous amount. It could be a couple of loaves of bread, could be 12 packets of biscuits, it could be a whole tub of ice cream followed by something else. It's an enormous amount of food. One of my clients said, I binge every day. And I said to her, well, what do you binge on? And they said, I had a piece of chocolate cake yesterday. And I thought, not actually a binge, but in her mind it was. So we work around that a little bit.
If we can turn our attention to some specific context now, because if somebody is perhaps intending to fall pregnant or has fallen pregnant and they've been diagnosed with an eating disorder, what's your frame of reference in terms of management? What are your thoughts?
Well, we're very concerned, of course, for the baby and the mother, and we do a lot of education around that, but we also work in more of a triage. So we need to have communication with the GP and effective communication with a dietitian. And each have separate roles. So the dietitian looks after the diet for the mum and the baby, which is very important. And if they're struggling because it is anorexia, they know the nutritional values of the food that they can feed for them to get enough. The GP will monitor everything else, of course, in the medical side of things. And the clinician usually just works on the cognitive issues and the behaviour around wanting to restrict. What I've found mostly when I have seen in the past a mum who's pregnant is that they actually come to you because they're now ready to change. So they're actually, my experience anyway, is that they're more motivated to change for the baby's sake.
Yes.
They don't want the baby to experience it. So the motivation's pretty high. And that's good, but that's not over yet. They've still got the challenge of getting through all those cognitive beliefs and mental rituals that they've been doing for probably quite a number of years. Yeah,
it's interesting, isn't it? Because we have to work long term with people. We have to maintain a sense of therapeutic optimism. And I guess, if a patient's coming into a GP surgery and metabolically they fluctuate between being stable and unstable, and their BMI is dropping and maybe they're admitted and then it comes back. Any suggestions for our colleagues in terms of just maintaining a sense of therapeutic optimism, because this doesn't behave like any other disorder, does it?
It doesn't behave like any other disorder, and it's not only the GP, it's the dietitian and the clinician involved. It's sort of really hard work because it is a bit of a roller coaster for the client themselves. 1 minute they're sort of in hospital and being refed, the next minute they're stable and you've got to get them to a certain point, and you think you're there and you've been sitting there for a little bit, maybe a month or so, and all of a sudden something clicks in again. Like the button switches over and they're dropping again. And I guess that's part of the sheer frustration of treating somebody whose condition does act like a roller coaster. I think though, just my only encouragement is just to talk to people, to keep it going, because I think you do eventually get there. Some take longer than others, and that can be the frustrating part, but I do think eventually they'll see the light. And it's so nice to have people come back to you and say, thank you. Maybe 12 months later, I had somebody move down to Wollongong, and I walked out, and in the waiting room here she was sitting there, and I thought, oh, she's come back to see me to say thank you.
Wow.
And that's nice. That's what you want as a clinician with anything. But with such a difficult, thing to treat, it's even better.
Yeah. Well, Marianne, thank you for your time.
You're welcome.
It's been invaluable, and I know that for our colleagues sitting out there and hearing your experience and your poise and how you manage such complex individuals and sit with them through very difficult times. Hopefully you find it reassuring, and I would like to reassure you that whilst this is not easy work, it is work that you should never do alone. I think operating within a team context is so important. Just a reminder that the GP Psychiatry support line is available to you, ready and waiting to help you. Thank you.